what I hope to do this morning is really just spur some conversation to think about how do we deal with the chutes and ladders of working with primary care and public health, and give you 3 examples, real-life examples that we worked through, which hopefully will remind you of situations you had, and for you to think about what was it that worked. Was it learning the language? Was it the culture? Was it the immediacy of the event that brought you together? And how do we learn from those items and then go forward? So here I am. And it is, I'm a brand new state health official. I'm laughing because John Arbach was in the audience and he was one of my mentors. And John Dreisner is in the audience and he was one of my local health directors. And I started off like I do everything else, running as fast as I could, optimistic that I'd be able to solve any problem, getting ready to climb every ladder. One of the things my 2 new bosses told me, Marilyn Tavener was the Secretary of Health for the state, and Tim Kaine was the governor of the state, is they said, we have some real issues with prematurity and infant mortality, and particularly with the disparities that that you need to address and make a difference. And I said, sure, I can climb that ladder. This will be easy. And then the next thing that happened to me, I'm still trying to push this, guys. Am I not? Was I got the report card. And I'm a little bit of an overachiever. I've got my MD and my MBA and my MPH, and I've never gotten a D in my life. And so when this report card showed up, and the very well-meaning, very kind, anybody here from March of Dimes? So 2 very nice women came into my office to share this with me with smiles on their faces and saying, so what are you going to do to fix this? And I was like, oh, shoot, a D is not something I want the governor to see. So I told the governor how proud I was that I got a D because we'd gotten an F the year before. But that we were going to be able to move it forward. So I was determined to do this. So what's the next thing you do? You call together your team, right? And we had a very good team in child and family health, but when I met with them and I asked them what they were doing, they would refer to things as, well, 10 years ago we brought on this, and 5 years ago we brought on this. So it was clear to me that our approach to prematurity and infant mortality was an approach that was very dyed-in-the-wool. We've been doing it the same way for a long time with the same partners. So we decided to shake it up. And, this is how I felt when I first found out. See, I knew it was going to be early in the morning and we had to have fun. How many of you have a Bitmoji that your children taught you into doing, So truly, this is how I felt. And so the first thing we did is I went after the data, because I believe in the Julius Richmond model of advocacy and how to make a difference. You need to have the data, the evidence. You need to have the societal will to make a change, and then you need to have the politics and policy in place. So I slid down that chute. I said, we're going to find the data. I learned that babies in Virginia were born Monday through Friday. The vast majority of infants in 2009 were born during Monday through Friday. As far as I knew, there was no good medical basis for that. I learned that our C-section rates varied very widely around the state, that were not consistent with risk or with the size of hospitals or what their care delivery was. I learned that long-acting contraceptives were not available to women at the time of delivery prior to discharge, because that we as a state would not reimburse for them, and neither would private health plans. So at least I had some data points of some very specific activities that we could work on. So what did I need to do next? Well, the next thing I needed to do was to get my friends together, and I had to get different friends that hadn't normally climbed this ladder with us. And that was harder than I thought it was going to be. But the good news is the power of your name and the tenacity of just hanging out and calling people. The gentleman who is in charge of AARP in Virginia, 4 phone calls, finally took my call and said, I really didn't think you were trying to call me about infant mortality. I kept thinking you had the wrong name. And I said, no, grandparents are very involved in caring for children. They're very involved. I asked him if he remembered how a baby should sleep. He told me on their stomach or on their side, and he said, that's why I need you on our team. So we wrote a number of articles and did a number of blogs with the AARP to teach grandparents what they needed to learn about helping to prevent prematurity and infant mortality. But we shared the story. We shared the story about the horrific racial disparities. We shared the one slide that showed the Monday through Friday births of babies in our state, and it resonated with people, so they got on the team. And as we climbed the ladder together, we did some of the things we talked about. We put in protocols, and these were voluntary protocols for elective C-sections around the state. It took many years. Finally, last year, even though I was in my role at the AAP, I got an email from our Virginia Hospital Association saying we finally have it in every hospital in the state, and the early elective C-section rate has plummeted in the state of Virginia. So not always a fast move. That was a 5 years to get there, but it happened, and it's now part of the fabric of what they do. We worked with our Medicaid partners and private health plans, and now in Virginia, LARCs are covered by all of the private payers and by Medicaid when given prior to leaving the hospital after delivery. So we also told our story everywhere all the time, and I can't stress that enough. I remember being in a room like this talking to adult gastroenterologists about certificate of need programs and why they had to work through the state to be able to open up an outpatient surgical center. And my last 4 slides were about safe sleep, because I said you all see grandparents and you need to understand and know how babies should sleep, and this may be the life you save this year. Fascinatingly, they all got very interested, and the talk lasted 10 minutes longer as they had conversations. So it's important to get your unlikely bedfellows with you. So what happened? I was very proud of this. We got a B. So Virginia is now, you can see down at the bottom, the state rank is number 6. So we moved from being a red state to a purple state to a blue state in terms, not politically, but in terms of March of Dimes. I would be nonpartisan no matter what I said up here, but success. But when we look back on that success, everybody will claim it, and what you should do is let them claim it. So, you know, the March of Dimes says we moved this needle. 2 different governors say we moved this needle. ACOG in Virginia says we did it. Everybody claims it. Everybody owns it. It doesn't really matter, because the bottom line is we move the needle, and that's what's really important. Although I will tell you, I did, when this came out, send an email to Secretary Tavener and to now Senator Kaine and said thank you, because it was your pushing to make us really look at this differently that started the ball rolling. And there may be thousands of people who now own this B, but it certainly took 2 people who were committed to have us start to look at the evidence differently to get there. So that's a great Chutes and Ladders story, right? I mean, that's an easy one. Now the next one we're going to go to, this is what turned my hair gray, but this is H1N1. So with H1N1, let's talk about beginning with the first few days of the epidemic. So some of you may remember that spring in 2009, there were a lot of cases in Mexico. Then we had in New York City, a middle school where there was a huge number of children who were infected in a short period of time. Once again, I got on the ladder, right? We know how to do this. We know where we're going. And this time, if you're looking at my Bitmoji, it's not just me, but it's the whole health department. My preparedness and response people were ready. They had their playbook. They pulled it off the shelf. They'd been talking about this for 10 years. They'd had a million meetings where they were going to plan for this. They knew what they were going to do with the bodies. They knew what they were going to do for infrastructure, critical infrastructure. They had it all. What was the problem? It was all based kind of on avian flu and on high death rates, and not in the disease impacting primarily children and pregnant women. So the plan and what we were seeing didn't jive up. So what's the hard thing there? You're climbing up the wrong ladder. So you got to figure out, how do I get off that ladder and move over to the next one? So what were our issues that we were struggling with that people really hadn't thought about? We had time once we kind of got through that first bump of disease. Through the summer, we continued to have infections. Then we had to think about, what are we going to do for vaccinations? And what hit us was, one of the biggest issues was N95 masks. Something looking back, you would have thought we all would have thought we'd need a lot to be able to handle the fact that everybody who came in with a cough and a cold and a fever might have had H1N1 and we needed to be protected, but we did not. So as a community, we needed to work with our primary care clinicians for them to understand. Very few primary care clinicians had N95 masks or even knew what they were. They were frequently going to Lowe's and Home Depot to buy the commercial ones that were used for painting to be able to stop small particles. Hospitals were livid because they could not get them. People didn't know how to fit test. And it was a huge, immediate ladder we had to climb together because we hadn't thought of that in our plan. Also, our plan was flawed because we really didn't think about children and pregnant women as being the primary people who would be infected. We had to very quickly ramp up, and one of the things that I was most impressed by, we put together 2 work group phone calls on a weekly basis, which was in the beginning partially because it's better to have your enemies close than to have them be taking pot shots at you. They quickly became not our enemies, but our allies and leaders, in that we talked to all the infectious disease experts in the state once a week. We talked to all the pediatric centers of excellence, the ICUs, once a week, and we talked to all the CEOs of the hospitals once a week. But particularly for the pediatric ICUs, we had never had in Virginia a way to know what beds were and were not available. And we were able to develop a registry that goes as far as Duke and goes up to Children's National so that we could start to see where are beds for children. Would not have happened, I think, naturally. It occurred mainly because there was a scarcity of beds, and we were trying to figure out how to care for those children. So during those first few weeks, we were doing better. And then we had to really think about who are our partners, and notice this time who's in the lead. So I realized as we were going through the end of the summer and we were dusting off that playbook again, one of the things in the playbook was that the health department would own all the vaccine and would get all the vaccine, and they would give all the vaccine. And it was clear to me, being a clinician and a public health person, that my clinicians in the state would do a much better job in many situations in being the trusted provider of a new vaccine. So you all may remember there was a lot of talk about the H1N1 vaccine. Is it safe? Is it not? They brought it through quickly. I can't tell you how many times I'd have people say, I want to get the vaccine from my doctor. I don't want to get the government vaccine. And they didn't realize they all came from the same place, but it was that trust factor. The other thing we knew that we needed to do was to get trust within our clinical community. So we made a unique decision, and it was very hard for our staff, in that we said, we're not going to drive the bus this time. We are going to take turns driving the bus, and our clinicians are going to stand right next to us. So every week when we got our allocation of H1N1 vaccine, 50% went to the clinical community and 50% stayed in the public health domain. And we also gave the flexibility to our local health officers to be able to move that around based on what they thought the particular needs of their localities were. But we knew, especially for women and children, vulnerable groups, it was important for people who were most likely to see them to have access to the vaccine as soon as possible. And many of you may remember, these were the long lines that existed when people came out to get the vaccine. And we were able, in Virginia, to shorten our lines significantly, but most importantly, by bringing on our primary care colleagues, by bringing in OBGYN and pediatrics. I'm always very proud to say that our vaccination rates in the first 8 weeks were 50% higher than the national average. And that was because our goal was, and we used to say we want to put as many needles in arms and as much vaccine up noses as we possibly can as fast as we can, because that's how we'll get the herd immunity in our state. And we did that very effectively. But the hard part here was public health thought they were going to be running ahead. We had to bring our partners with us, and we had to let them be in front a lot of the time. And there were a number of dynamic conversations. I always say dynamic when they're heated, but dynamic conversations with local health officials who said, wait a minute, I have a plan. I have tested this plan. I have practiced this plan. This feels different, and this doesn't feel right. We know how to give vaccines to people as they drive by in cars. That's what we want to do. And I'd say, but I have a lot of moms and children who don't want to drive by cars and get shots from you, and I need them to have access too. So that flexibility in your conversation with primary care and public health is so important. So the last situation we're going to talk about is a time where nobody could figure out how to climb up the ladder. And everybody, primary care and public health, were just not pulling themselves together in the way they needed to be able to meet the needs of the community. So this is has become a very dear friend of mine, Dr. Mona Hanna-Attisha, and everybody's seen her picture everywhere. But the interesting thing is when you talk to Mona, she talks about how You know, she has her MPH. She has learned epidemiology. She knew that there was an issue with the water being a different color. She started to see high blood levels in children. She went to who she thought were the people that should help her. She went to local public health. She went to state public health. She did everything she was taught to do in rooms like this, right? And she couldn't get anywhere. She went to her local medical society. She actually went to adult physicians to say, sometimes you have stronger voices than me. Can you help me? She still couldn't get anybody to climb that ladder with her. So what did she do? She did two things. And if you think about the Julius Richmond Triangle of Advocacy, she got evidence, and she published her evidence. And then she also used social will because she couldn't get political will and policy. So I think a lot of people talk about Mona and they think of her as being a superstar. I think of her as being a great scientist, because what she really did is not only did they measure the blood lead levels, but they used rigor and they used the ability to publish it and to be able to demonstrate that analysis of what her lead levels had done and how they'd risen. They couldn't find anybody in their state to help them with testing the water, so where did they go? Virginia Tech. Go Virginia, came and helped them test the water over a summer. So she could, again, using that triangle of advocacy, get the evidence she really needed to continue to push people to do what needed to be done. These are just examples of where the lead levels have gone. And I think what Mona would tell you, she would tell you this every time, but what Mona would tell you, she still doesn't understand why she couldn't get the traction she needed with having evidence and science and partners, and had to go to a much more dramatic approach, which was getting social will on board. But she's glad she did it. But I think the other most important thing that Mona would tell you if she were standing here is that she's learning and growing in how to work with public health and primary care, because she knows she needs to in order to be able to improve the health of the children of Flint. Her goal ultimately is to make sure they have the very best childhood with the very best wraparound services they can have, because they were exposed to lead in the water. But she also understands this is an issue across the country, and her hope is that other people don't go through the same fight she had, but can find those partners and can bring those partners together early on. Because a lot of energy, again, Mona will talk about how, you know, she spent about 8 months of her life wrapped up in not beginning to get services to these kids, but just trying to get people to understand and hear what the issues were. So I challenge all of us here to think about, how do we not keep climbing our own ladder, but look around us and say who else might be there to bring them with us or to switch over to a different ladder. So we'll have less chutes. And then to continue that analogy, when you slide down the chute and you're at the bottom, see who's down there with you. Because if you can pull them up, you can actually end up in better places. So I'll leave and open up to questions. I go back to, and I didn't bring a picture of the Julius Richmond Triangle. And those of you who may know Julius Richmond, he was an individual who was famous for helping start Head Start. And one of the things that he was passionate about was a very simplistic way to look at problems that impact the public, and then to be able to think about your solutions. And so I always go back to evidence. Do you have an evidence base, or are you evidence informed? Because you can tell great stories, but you have to have the evidence behind you. Whether you are in public health trying to get your primary care colleagues on board, whether you're in primary care trying to get your public health colleagues on board, then you have to have social will that this is important enough for people to change. And if you go back to that talk about infant mortality and prematurity, I had to get the AARP on board. Because even though they didn't initially think it was a big issue, who's the biggest lobbyer in your state government houses, right? The AARP. So the first day that they stood up with me to testify at Senate Health and Welfare, it was huge, because it was like, wait, they think this is important? Okay, now maybe we'll pay attention to all those public health, you know, bleeding hearts. So that's always very important. And then determining when you have the political will. In our state, the issue of prematurity and infant mortality, because we switched governors, was never going to be, it was never going to be mandated, it was never going to be regulated. We knew that we had to work one step at a time with every different organization with voluntary approaches to move things forward. And we did, and it's being realistic. I know I always tease him, and I think John Arbach's not in the room, but many of you, you all know who he is, and some of you may know Tom Frieden. And Tom came to visit Virginia when I was the state health official, and was complaining about our very low tobacco taxes. And if you know Tom, he likes to go for walks. So I said, come with me and let's go walk over to the State House. We walked in the State House, and I said, look around the ceiling. And he looked around, and he goes, it's pretty. And I said, what are those? And he goes, what do you mean? And I said, those are tobacco leaves. I said, this is the commonwealth that tobacco built. So we have to go one step at a time, and we can't become too impatient or too strident that we don't bring the society where we need to go. So with that, I'd like to have you all tell me what's a ladder you're climbing or a chute you fell down that you think other people could learn from so we don't do the same thing.